So I'm going to talk very briefly about patient selection, and then we'll get into the meat of the discussion. I have a few disclosures, but none that would affect this discussion. We're going to start with the hypothesis that salvage treatment after chemoradiotherapy failure is feasible and effective, and that appropriate and adequate patient selection improves outcomes. And as you can see here, is this going to help when you're on a motorbike with a gas canister? Is that feasible? Is it effective? Who knows? But we certainly know that laryngeal salvage surgery is feasible. This is from the RTOG study. 100% of the recurrences could have laryngectomy. And it seems that it's reasonably effective because, 2-year survival was about 74%. When you look at oropharyngeal, it's a different case. This is a series from MD Anderson. Much fewer cases are eligible for salvage, and when they're salvaged, the outcomes are much lower. So I guess patient selection is therefore key. Who of these should get the chop or should get the treatment? And when we started looking at that, we decided to look at the literature so that we can benefit from the experience of others. And so the predictors of good outcome tend to be divided into three areas. There are tumor factors. So, if it's a laryngeal recurrence or a second primary, it has a better outcome. Small localized tumors have better outcomes. If you've got no neck disease on recurrence, then there's better outcomes. Recurrence occurring 12 months or more after treatment. There's some controversy about that, but certainly patients recurring within 6 months certainly tend to have a persistent disease, and it's a worse prognosis. No extracapsular spread, and in one paper, an eGFR of less than 80% seemed to predict better outcome. In terms of patient factors, if you're a non-smoker or if you stopped smoking, you have a better outcome. General health, ECOG, state 0 or 1, a good psychological state, if you're married, and also if you're religious or spiritual. What about treatment factors? Well, if you've had no previous radiotherapy or chemotherapy, then this is a predictor of better outcome because you're going to be able to get more treatment. No toxicity from the previous treatment goes without saying. If you're able to resect that tumor with no gross tumor left and no surgical margins, then the outcome's better. And if no vital structures are involved, the carotid arteries, brachial plexus, etc. And finally, by involving patients in shared decision-making, their outcomes of their acceptance of whatever happens afterwards is better. So at the Institute of Head and Neck Studies and Education in Birmingham, we have a recurrence and complex patient clinic, and we developed a protocol, essentially an evidence-based protocol for the assessment of a patient with recurrence. You see there a detailed history, examination, PET-CT scan, an EUA and biopsy. It's a form of anesthetic assessment as well as getting research biopsies, but also tells you a lot about the tumor itself. Speech and language and dietetics assessment, and then any additional imaging that you would require for surgical and radiotherapy planning. I don't have time to go into the evidence base behind this, okay? But this is the assessment protocol. But what is important is after that assessment, there's a kind of 10-step protocol for decision-making as to what kind of treatment those patients get. And that 10-step protocol, I'll share with you very shortly. What was the previous disease and treatments? Are there any poor prognosis features, involved margins in the initial treatment? What were the details of the radiotherapy field? Were there any geographic misses? What levels and what structures were sacrificed in the neck dissection? And what's the time since last treatment? Also, have there been complications or toxicity of previous treatment? dysphagia, osteoradionecrosis, etc. Is there any evidence of distant metastasis? Because that's a game changer. And then if there isn't, is there recurrence at the primary site? Is there recurrence, and is it actually recurrence, or is it a second tumor, a second primary tumor? What's the extent and size of that recurrence? And if there's recurrence in the neck, is there recurrence in the neck? What's the extent and size of the recurrence? Is there evidence of soft tissue extension or nodal extracapsular spread by physical examination or on imaging? Because that's going to also determine the kind of response and outcome that they're going to have. And of course, is there any evidence of involvement of the carotid arteries, brachial plexus, prevertebral muscles? Because again, these are game changers and suggest that you're not going to be able to take that tumor out completely. Can the recurrence, therefore, with that assessment, be surgically excised with no gross tumor left behind? Is it possible to give more radiotherapy? What about chemotherapy? Will there be new vascularized tissue introduced into that area to help that? And what are the potential deficits of the treatment as a whole? Not just the surgical treatment, not just the radiation or chemoradiation, re-irradiation. And finally, what's the state of the patient's reserve? Psychological state, general health, family support. You know, it's fine treating them, but if they don't have all that, then, you know, there's a big question as to whether you treat them at all if they're not going to be able to cope with their treatment. So, in summary, patient assessment and selection is crucial. I'd like to thank all the team back at base, and I'm going to leave you with a very, very short video to just show you that it's very important to plan your assessment of recurrence, know what you're going to do, and so that you don't run into any surprises. Please run the video. You didn't plan that approach, I don't think. With that, I leave you, and thank you very much for your attention.